Uh, for- Awesome. So what I'll do is I'll start off just thanking everyone for joining. We love these Connecting California sessions because they're sort of small, intimate sessions with fellows across the state. And we join and we talk about interesting topics that might not be represented at everyone's programs. And really the champion for all of this is Liana. She is our Master of California ACC, in charge of everything. Nothing happens without her. So we really thank her for joining and for helping us put together all this programming. So thank you, Liana. And thank you to our two speakers today. So the series Connecting California was created by our FIT committee, and we have a lot of our FIT committee in attendance today. And essentially we invite speakers from programs across California to talk about various niche topics that may or may not be represented at all of our fellowship programs. And we ask them to talk about their clinics, sort of the logistic of their clinic, and then to highlight unique patient cases from their clinics. And these topics really could run the gamut of anything. We're all here for the learning. So thank you all for joining. We have two fantastic speakers today. We'll start with Dr. Justin Parizo first. So he will be talking about LVAD today. So I'm sorry, it's Justin Parizo. Correct me if I'm wrong, Justin. And actually, I think he might have gotten kicked off. Uh-oh, I don't see his name anymore. I wonder if he had a bad connection. Let me text him if everyone bears with me for a moment. And if I don't hear from him in a few minutes, then we'll start with Dr. Delling. Okay, if you don't mind. Okay.
Oh, there he is. There he is. Okay, I'm okay either way. I can go afterwards.
Okay, Justin, we lost you. You're back. Are you ready? You're ready to go first? Oh, you're muted. Uh-oh.
Uh-oh.
Justin, you're muted, or your mic is not working.
Oh, can you hear me now?
Yes, perfect.
I got like booted off when you started recording, I guess.
Okay, so let me introduce you and then you can go ahead and start.
Okay, sure.
Okay, so Dr. Justin Parizo is an advanced heart failure and transplant cardiologist at the San Diego Cardiac Center and Sharp Memorial Hospital. He completed his medical school training at UCSF, followed by training in internal medicine, cardiology, and advanced heart failure transplant cardiology at Stanford. He's published on numerous topics in heart failure, including trends in readmission and mortality following heart failure hospitalization in the VA healthcare system. And he's published on cost effectiveness of guideline-directed medical therapies and variation in access to heart transplantation. We're super glad that he's here today to talk about LVAD. This can be a niche topic for many fellows. And for those of us that are interested in advanced heart failure and transplant, this will be our bread and butter. So thank you so much, Dr. Parizo, for joining us.
Of course. Thank you so much for having me. I'm going to share my screen here. Okay. Can you see that okay?
Looks good.
All right, good. Okay. Well, thank you so much for having me. It's an honor to have a chance to talk with you all. I'm going to be talking about LVAD clinic and kind of doing a review of LVAD clinic structure, the way that our LVAD clinic works, which I think is similar to probably most LVAD clinics, and then discuss a case at the end to kind of illustrate how the flow works through our clinic and how you can kind of catch things if there are issues. I just put these pictures at the bottom just to illustrate, the progress that LVADs have made from the NovaCore there on the bottom left, which is actually in Dr. DeBakey's hand, to the HeartMate 3 over on the right, and doesn't cover all the LVADs that there have been, but the majority. Oh, it's not letting me advance. There we go. So I don't have any disclosures. So this is a general structure of our clinic, and you can see the picture over there on the right. That's our actual clinic. But there's a lot of players involved. It takes a lot to run an LVAD clinic. We have 7 LVAD nurse practitioners who essentially run the clinic. We have 2 psychologists who are incredibly helpful, both helping patients, in the early process as they're coming into the LVAD with advanced heart failure, and then handling a lot of the issues that they face, after LVAD implantation, dealing with chronic disease, loss of family members, loss of functional capacity, and comorbid site conditions as well. We have a social worker who's incredibly helpful, especially with our socioeconomically disadvantaged patients. We have a pharmacist. We have 3 LVAD attendings, including myself. We have a medical assistant who does our intake. We're fortunate enough to have a lab in clinic, and we have lab techs who draw blood in clinic. And then we have our 2 MCS coordinators who, along with the 7 LVAD MPs, really run the show in our clinic. I just gave a little bit of data on our program and who we see in our clinic currently. We have a pretty big or a relatively large HeartMate 2 compared to HeartMate 3 population. We have 46 total LVADs that we follow outpatient. 28 of those are HeartMate 2 and 18 are HeartMate 3s. Our program had implanted one single HVAD patient, but unfortunately that patient has since passed. So this is the general LVAD clinic workflow. Patients come in, and like any clinic, they go through intake. And then, as I said, we have a lab in clinic, and so they have labs drawn. Our MCS coordinators will then take them into a room and do their evaluation. I'll go into some detail on that. And if necessary, they'll get an echo and a ramp study. And patients aren't getting an echo with every visit, but with a fair frequency in our clinic. And then the LVAD transplant nurse practitioner will see them, and then we'll do the attending visit, and finally do we have a form of clinic review, which I'll go into. Our LVAD general lab, the LVAD clinic labs that we do is we'll do blood count, CMP, LDH, INR, kind of the standard things that you would think of. And then oftentimes, depending on the patient's comorbidities, we'll get hemoglobin A1C, lipids. If they're on amiodarone, maybe we'll do a TSH. And then a UA if we suspect they may have an LVAD thrombus or something to that effect. So when patients, they've come into clinic, they've had their intake, they've gotten their laboratory tests, then the MCS coordinator sees them, as I said, and the MCS coordinator has a lot of work to do. We have the Intermax requirements that we have to meet. So every really 6 months for patients, we have to do a 6-minute walk, trail making, which is this neurocognitive test that you see over to the right. That's kind of a general screening test, and then a quality of life survey. And then we also are required to do that at month 1 post-implant and month 3 post-implant. So patients will get those fairly often. And then we're also required to do equipment checks, which of course you would do anyways. But every visit, we evaluate patients' clips. And I have a picture here of the equipment that an LVAD patient would have. These are the clips that essentially attach the batteries of the LVAD, which each of these 4 things is a battery here, to the LVAD. And I apologize, I'm sure a lot of you kind of already know a lot of this, but I'll go into sort of more detail maybe than I need to, just for clarity's sake. So they'll have their clips evaluated, their batteries evaluated. We check their batteries for battery life, make sure that all their batteries are holding a full charge. And then we check their controllers, make sure the internal battery still has at least 6 months left. And we check their backup controller, which is an additional controller that all of our LVAD patients will have that has the same exact settings as their controller. And it's essentially something that they always have in case they have a controller issue. And they have to do something called a controller exchange, which you hope to never have to do, but patients do have to do from at times. And then Intermax also requires an annual check of basically everything that an LVAD patient has. So that includes the clips and the batteries and the controllers, as I said. It also includes their mobile power unit, which is how they hook up to wall power from their controller to their LVAD. And then a lot of their carrying equipment, which I'll tell you a little bit more about. The MCS coordinators also do home safety checks. So one of the most important things is evaluating for falls. Our patients are obviously anticoagulated, but they're often frail. and are often on the older side, so they have orthopedic issues as well. So it's important to assess for falls. And then I think home safety also includes asking about their caregivers. We have many patients who end up outliving their caregiver support. And so ensuring they're safe at home is really important. Electricity access is critical. We're fortunate to only have a few patients who live in trailers or have sort of not the best or consistent access to electricity, but we find ways to help them manage. But I know some more rural programs, I think, struggle with that a bit more. And unfortunately, some patients actually get turned down for lack of electricity access, which I saw during my fellowship. And then we ensure they have equipment like a shower bag, which is a really critical piece of equipment for patients with an LVAD. It's a bag that all of their equipment can go in because obviously this equipment can't get wet, so that they can bathe themselves safely. The MCS coordinator will also confirm their anticoagulation strategy. Almost all of our patients are on warfarin, except for patients who are intolerant of anticoagulation, which does happen, especially in your patients who live longer. And we internally don't manage INRs, so oftentimes we're ensuring that the primary is managing it or an anticoagulation clinic is managing their INRs. Then, as I said, we review their carrying strategy for their LVAD, and it's actually really, it seems not so important as it is, but the way that they carry their LVAD really affects their quality of life. And you find that some patients find the perfect strategy, something they buy on like Etsy or something like that really changes their life because they're able to carry their LVAD more easily, and so it becomes less of a burden for them. Then we do driveline checks, and this is a driveline. So this is the driveline exiting the patient's abdomen. This is a nice, clean looking driveline site. There is some dermatitis or adhesive reaction or something, but we see that commonly, and that's okay. And the driveline is just checked, and we review their sort of strategy for addressing their driveline with them. Then we check alarms, which we'll get from our LVAD monitor. This on the bottom here is kind of the older monitor that we used to use, but now we have these like kind of iPad things that give us a bit of a more detailed view of the LVAD parameters over time. If any of you remember or still see patients with HVADs, it's kind of more akin to that, where you can get a more granular view. Whether it's that useful or not, I'm not so sure, but it's nice to have. And then we document their current parameters just to ensure that they're stable from prior and that there's no concerns there. And just to say, for anyone who doesn't know, the standard parameters, and you probably all know, are the flow, the estimated flow, the set RPM, so the speed with which the VAD is spinning, the pulsatility index, which is kind of complicated, but it's in many ways just a measurement of the degree of pulsation coming into the LVAD. A little more complicated than that, but essentially that. And then the pump power, it's the output that is actually measured that the pump has to put in to spin these RPMs. So then after the patient is seen by the MCS coordinator, they'll be seen by the LVAD nurse practitioner. The LVAD nurse practitioner has a lot of overlap with the history and the evaluation that the MCS coordinator does, but they get more granular on the history and the chief complaint. They'll go into a review of medications. They'll check healthcare maintenance. They generally will be reevaluating or concurrently evaluating the driveline and alarms. And then we're fortunate to have one of our LVAD nurse practitioners is a former EP nurse practitioner. And so we have the ability to interrogate devices in clinic and have all of the programmers there, which is really, really nice to have in your clinic if it's available. And then finally, the attending visit. So our nurse practitioner's MCS coordinator will come and discuss the patient with us in the office. And then we will, review everything that they've seen, as you guys, I think, probably do with your attendings in clinic, and then come up with a plan. We're generally reviewing an EKG, and this EKG here is a regular AV-paced HeartMate 3 EKG. Review the echo if an echo is available, and then review the ICD interrogation. We'll also go over labs if they're available. Generally, they aren't because they've just been drawn, but sometimes they are. We'll decide if we're going to have the MCS coordinator send log files, and log files are actually a more detailed documentation of the parameters that the LVAD has seen over time that we can actually send in to have evaluated by the engineers, and they can give us a even more granular view than even the new Abbott iPad monitors give us. For ICDs, I just wanted to quickly mention our approach to ICDs, just because it's something that we address often in clinic. We generally are turning off the LV lead for CRT-D devices. We don't implant as a rule ICDs for all LVAD patients. I believe some programs do that. We don't, but most of our patients end up with ICDs. We may increase RV pacing pacing rate to help support the right ventricle. And then we do generally take a strategy of having a higher threshold to provide therapies, especially defibrillations from our ICDs in our LVAD patients, just because they tolerate ventricular tachycardia so well. We'll often discuss heart failure, goal-directed medical therapy. We don't do it universally for patients, but certainly for patients where we're attempting to do a bridge to recovery strategy, we will. You can see a patient here who has had a significant improvement in her LV function. She had about a 6-centimeter ventricle with an ejection fraction of 15%, and she's come a long way since then. She does have a significant degree of RV dysfunction. She's still currently implanted for lots of reasons. And then we'll discuss transplant candidacy, which I think used to be a bigger thing in LVAD clinics. More and more patients are quote unquote destination therapy, if that's even a designation anymore. But most patients who are being implanted are just going to be implanted, and given the UNOS allocation scheme now, are not going to be transitioning to transplant. But we still sort of consider candidacy, because every once in a while we have a patient who gets transplanted from LVAD. This is a list of things that I put together that I think is probably among the most important takeaways, which is just things to watch out for in LVAD clinic, what you don't want to miss, because I see this as largely my role in LVAD clinic, because 90% of patients I think could be perfectly managed by the nurse practitioners and the MCS coordinators. And so I kind of focus my time on making sure we're not missing any of these things, which is falls, which I kind of already went into, and then bleeding and anemia, which patients on anticoagulation, often will have and you need to watch out for. Hypertension, which I think is one that gets missed a lot. I recall in my fellowship, that would seem to get missed a lot, and in our clinic, it still does. I frequently have blood pressures reported to me that are something like 110/50 on a patient who I know has an aortic valve that doesn't open at all. And when you truly get a Doppler opening pressure, where you use a Doppler to measure the first pressure as you deflate a manual blood pressure cuff, you find that their estimated MAP is 110 or something like that. So something to watch out for, and in a way that you can really help a patient in the long term. Aortic insufficiency is another thing to think about. A lot of our LVAD patients end up with continuous aortic insufficiency. As you can see here, this woman's aortic insufficiency progressed over time, and she actually ended up getting a TAVR, which is one strategy you could take, but by no means the only strategy for continuous AI. She had a recirculation of over 2 liters per minute, and so obviously was having significant symptoms of left ventricular failure. Also, we watch out for RV failure. We watch out for LV failure symptoms, indications that maybe we need to increase the speed of the LVAD or improve the LV filling in some way. We check alarms, as I said before. Ooh, sorry about that. We consider the possibility, especially with our large HeartMate 2 population, where the outflow graft is prone to kinking or narrowing. We consider the possibility of narrowing. And these pictures here are actually a patient from last week that was caught in clinic, just wasn't feeling right, was brought in and had a CTA that showed that there was a kink in the outflow graft. And here you can see, as they're injecting contrast with the pigtail, there's sort of a narrowed flow of contrast, which really should be following this contour out here. And they ended up putting a non-covered stent in there and ballooning it. And you can see the IVUS here before, with this invagination of the outflow graft, and then post a nice round outflow graft. And the patient did really quite well. We monitor drive lines very closely. And over here, you see a normal or probably normal drive line. We do 3 stages. Some papers suggest that you stage drive lines in 5 stages. I don't think it really matters. I think you know a bad drive line when you see one and what you need to do. But this next picture is stage 2, where you have kind of a cellulitis, local infection, and this is a deep infection that might involve muscle or fascia. And then evaluation for thrombus, hemolysis, etc. And this is supposed to represent Coca-Cola urine, which patients who have significant hemolysis, who have thrombus, may at times have dark brown urine. All right. Clinic review. We actually in our program don't have a formalized clinic review. In my training, we did have a formalized clinic review and I actually liked it a lot. I think we probably in the near future will implement it. The way that our clinic functions is we have tests, labs, things that need to be followed up on, like blood pressure, and the nurse practitioners will follow up on those and then give patient callbacks and review with attendings as needed, especially for urgent stuff during the week. And then if anything is really minor, then it'll be reviewed before the following clinic the next week. And then we as the attendings are reviewing things on our own. I do think it would be nice, though, if we had a formalized clinic review. I think it's nice to have more providers weighing in on what you're doing for any patient strategy. It's a nice time to ask questions, make sure that no one else has concerns. I like that approach. And then we have we're fortunate enough to have the ability to do emergent NP visits. It's a nice way that we manage to keep a lot of our patients out of the emergency department. Patients who might be sent in generally can come into clinic and be seen on an emergent basis, which I think if you have the ability to do that in your future LVAD programs, if that's what you go into, it's a really nice thing to be able to provide for patients, and patients appreciate it. So this is a quick case, and I think I just have a couple more minutes. But this gentleman, I picked to describe him mostly because he himself is a very interesting man. So he's a 71-year-old male, ischemic cardiomyopathy. He was implanted with an XVE LVAD, which I imagine none of us have seen. I certainly haven't, in 2002. And then was exchanged for another XVE in 2004. And then in 2005, again, was exchanged for a HeartMate 2 and has ever since had that HeartMate 2. And he, to my knowledge, is and I think it's correct, the longest standing continuous LVAD implant in the world. And he recently had a clinic presentation for a decompensation, which I'll describe here. But his course, as you would imagine, being as long as it's been, has been complicated by right heart failure. He's had ventricular arrhythmias, driveline infections, driveline breakdown with wire exposure. He's also, unfortunately, developed some degree of cognitive dysfunction. And because he's lived so long, he's outlived all of his caregivers and has had a loss of his support system. So he recently called in and said that he needed an earlier visit. Our MCS coordinator, after he came in and got labs, did the initial intake. And she found that he was having or had a low voltage alarm. I had made that plural, but it was actually a singular low voltage alarm. And then he had new, again, exposure of his drive line actually down to his skin with wire exposure, which is not ideal. And he had a Doppler opening pressure of 88. His aortic valve doesn't open. A heart rate of 70, and he was V-paced. His interrogation showed he had a HeartMate 2, as we know. It had been in for 6,542 days. The pump speed was 9,600. His median pump flow was 5.7. His pulsatility index was 1.95 median, and his power median was 6.25. This is his driveline, where you can see it's a little hard to tell here, but basically the covering has been torn away just from time. And this is exposure of wires there at his skin. It being at his skin, it makes it tough to access, tough to repair, and tough to address. I'll show you a picture of what we attempted to do. Next, he saw our LVAD MP. They also noted that he had marked lower extremity edema. He had weeping blisters in his legs and was severely dyspneic. He had been skipping Lasix doses kind of for unclear reason. And then we got an ICD interrogation there in clinic that didn't show any VT or any therapies. He had an echo in clinic that showed severe RV dilation, the LV dysfunction that we presume he has with his LVAD. His RVSP was 38. As I said, no aortic valve opening, and then severe TR and a right atrial pressure of 15. He had labs drawn in clinic, which were largely benign. I think not as bad as any of us might expect with this presentation, most notable for a BNP of 462. His chest x-ray, which we did to evaluate for pulmonary edema, showed pulmonary edema, but also we did a few x-rays to evaluate his driveline throughout the course from where it comes from his actual LVAD to his skin, and this actually goes further out, and we saw there were no internal fractures, and this was just a concern with the low voltage alarm. This is a picture of his echo, where you can see his LV is somewhat sucked down, but in other views it doesn't look quite so bad, and then significant RV dysfunction. So our plan for this patient, he was directly admitted to the hospital from clinic. He was diuresed 30 pounds. He felt a whole lot better after he was diuresed. And fortunately, he didn't need any additional support for his right ventricle with inotropes to achieve that diuresis. You may remember he had over 5 liters of output from his LVAD, and he was actually fairly easy to diurese. And that's part of why I think he's lived so long. His creatinine did increase to 1.6, which I think is probably his true baseline. Fortunately, after he was diuresed, his abdominal distension decreased significantly, exposing more of the driveline, and we were able to do this rescue taping, which for your sort of older, longer standing LVADs or your LVAD patients who maybe aren't so good at taking care of their driveline, rescue tape is critical. And then he obviously got heart failure re-education to try to help him start taking his diuretics again. LVAD safety re-education from our MCS coordinators. It appeared that he had probably just run his batteries down too low for the low voltage alarm. And then maybe most importantly, our psychologist met with him daily and continued to meet with him frequently to try to address a component of depression that I think was leading to poor self-care and not being in touch with our clinical team that got us into that situation. So some conclusions and just to round things out, I think clinics generally have a pretty standardized workflow. I don't imagine this clinic sounds too different from any of the other clinics you all have been in. I think the most important thing is to be systematic and for it to be a thorough evaluation. The good news is most LVAD patients are doing great. There are a short list of things that you really can't miss that I listed out for you. And then, it takes a village to run an LVAD clinic, and, managing an LVAD patient mostly happens outside of clinic. And so having a great staff who can sort of do all those extra things for you and do them well really makes your life easy. And with that, I'll conclude. If there's any questions, happy to answer.
Awesome. Wonderful talk. Does anyone have any questions right off the bat? If not, a question that came in for you. In terms of patients who you're discussing bridging to recovery, and it probably depends highly on the original etiology for LVAD placement, but do you have sort of a sense of the timeline for when you would think that you're going to be successful or unsuccessful?
It's a great question. I think that is in some ways programmatic. I think there are programs, not ours, although I think it's a fine strategy, where you have a patient who's critically ill in the hospital, and you think that they have a good chance in the short term of recovery, they just need time. And that could be almost any sort of patient. Myocarditis kind of comes to mind, although most fulminant myocarditis patients who are going to bounce back, I think bounce back pretty rapidly. Post-MI, post-cardiac arrest, if you just can't get them off, I think it's a consideration. And I do think some programs, particularly on the East Coast, do an early implant of a dischargeable LVAD with a plan to explant if they are able to do that. We actually had a patient recently where we discussed that strategy. In our case, it was a patient who we felt was so sick that we thought that they would imminently deteriorate, but was a blood type O who was somewhat sensitized and didn't need ECMO. And so getting them transplanted was going to be difficult. Fortunately, they ended up getting transplanted. But it's a consideration there. I think otherwise, it's just something that you monitor over time. And, I think you just continue to have it in the back of your mind. The potential that, this patient could recover. We've had a couple patients recently who were either considered for explant and turned down, or one who was explanted because he had improved so significantly. That patient was also a swimmer, and he desperately wanted to swim again. And so he sort of really pushed us, which is good in some ways because it got us to increase, his GDMT more, and he made incredible strides and had his LVAD explanted. But I don't think there's any one strategy. I think if you're not achieving it really early on, in a matter of a few months, then it can be at any point thereafter. But I wouldn't expect someone who you've had on a LVAD for all that long to be explanted, like I'm talking 4 years plus 5 years, just because you may be explanting them to pretty significant RV dysfunction if they've been implanted for long enough and have developed a bad right ventricle.
Awesome. Thank you so much. So that was a great talk from Dr. Parizeau. So if anyone missed the beginning, it'll be recorded and placed on our ACC Fit website. So we'll move on to our second topic today. So in the spirit of our mini lectures, we're trying to get as much knowledge crammed into 1 hour as possible. So we're super excited to have our next speaker, Dr. Francesca Delling, invited by our Fit Committee member, Paul Morano. So Dr. Delling is an associate professor of medicine at UCSF. She completed her internal medicine residency at Boston University Medical Center and her cardiovascular and cardiac imaging fellowships at Beth Israel and MGH in Boston. She also has an MPH from the Harvard T.H. Chan School of Public Health. Her clinical interests currently include valvular heart disease with a focus on mitral valve prolapse. Her research has focused on mitral valve disease and the combined use of echo, MRI, and genetics as tools to understand disease mechanisms and progression. She's an NIH-funded investigator, and we are so incredibly thrilled that she's here today to talk to us about her niche mitral valve disease clinic. Thank you so much, Dr. Delling.
Thank you, Natalie, for the introduction. So I'm going to share my screen. And let me see. I think I need Justin to, there we go.
Yeah. Sorry about that. I'm trying to, okay, there we go. Stop share.
Okay, great. All righty. So let's see here. Screen and here, and I'm gonna put it in a slide presentation. Okay, do you see it? Okay.
Yep.
Okay, perfect. All right. Okay, so thanks again for having me. Thank you, Paul, for inviting me. So my talk is actually about a niche of a niche. I can't think of any more niche than my clinic. It's very research focused. And I see, all types of mitral valve prolapse patients, from individuals with significant mitral regurgitation, moderate regurgitation, but I see a lot of MVP patients with ventricular arrhythmias that are being referred more and more nowadays, since the topic of sudden cardiac death and MVP is quite popular right now, and a lot of literature is coming out. So I get many referrals also from out of state. And my clinic, again, is very entangled with research. So prolapse is a fairly common valvular disease affecting up to 3% of the general population, almost 8 million individuals in the United States. It's the most common indication for mitral valve surgery in the Western world. Sorry about that. And basically, we have these myxomatous changes in the leaflets, which makes the valve quite floppy with elongated leaflets that are displaced into the left atrium. And the echocardiographic criteria for MVP is 2 millimeter displacement. So if there's displacement, there's malcoaptation, which leads to significant mitral regurgitation, as in this example with bileaflet mitral valve prolapse. So, management of severe MR is straightforward. There are fairly clear guidelines. Just as a reminder, if you have severe MR based on the echocardiographic criteria shown here, and you have symptoms, it's a no-brainer. You get mitral valve surgery, class 1. Repair is preferred. Also no-brainer if you have no symptoms, but you have systolic dysfunction, specifically an EF that's equal or less than 60% in a diameter that's greater than 40 millimeters. Really, the interesting category among MVP patients are those with no symptoms and normal LV systolic function. And actually, I wanted to bring this up because I see among fellows often the idea is that if a patient doesn't have symptoms and their EF is normal, then they don't need to be referred. And often we forget about this class 2A indication. So if you have surgical mortality that's less than 1% in your center and a greater than 95% likelihood of successful repair, then you should be referring your patient to surgery. So, severe primary MR, a number of my patients, and then patients with arrhythmic mitral valve prolapse, often the two are kind of fused together, one progresses into the other, and vice versa. But kind of focusing on the arrhythmic MVP phenotype, the yearly incidence of sudden cardiac death in mitral valve prolapse ranges between 0.4 and 1.8% in patients that have a flail leaflet and severe MR. So overall MVP is benign, but in a small percentage, there is the risk of death. And interestingly, only 23% of sudden cardiac death cases in MVP are explained by severe MR. And also 7% of sudden death in individuals that don't have severe MR and are young. It's quite a high percentage based on a postmortem study from an Italian group in University of Padua. So despite these percentages, which are quite alarming in my view, there are currently no indications for primary prevention ICD. And the reason for this is that it's still a challenge to identify those few that are at highest arrhythmic risk, that are at high risk for death. So what do we know so far? So in terms of the of severe MR, as mentioned, the 1.8% yearly rate of sudden death is shown here. In this paper from Mayo from a number of years ago, from the late 90s, surgery actually independently and favorably influenced the risk of sudden death. So, for a number of years, I was taught you just treat severe MR with surgery and you basically get rid of all of the risk that is implicit in having mitral valve prolapse in arrhythmias. But then came this paper, which was only a very small sample of survivors of cardiac arrest and about, I think, without any other cause of a sudden arrest. So no cardiomyopathy, no ischemia, no channelopathy. About 40% of these patients, there was evidence of bileaflet prolapse, and interestingly, only with mild MR, or most moderate. Typical EKG changes shown here with these inverted or biphasic T waves. And importantly, this high burden of PVCs, which are typically polymorphic, so very scary looking. So they're usually coming from the outflow tract. They can alternate with papillary muscle origin or fascicular origin, plus minus non-sustained VT. And usually it's a pretty high burden, at least 5% burden of PVC. And this type of ectopy is called complex ventricular ectopy in a number of papers. So from an echocardiographic perspective, basically what happens is that the leaflets prolapse, and there's, as shown in this clip here, there's tugging of the papillary muscles, and there's this curling motion of the infralateral base of the left ventricle, this kind of rocking motion that you can appreciate in this example quite well, where basically this infralateral base is apically and inwardly displaced. And you can have, together with these abnormal mechanics. You can have annular expansion as well. All of this can be augmented by annular disjunction, which is shown here live. This is a still frame. Basically, disjunction is nothing else than a separation between the myocardium and the attachment of the posterior leaflet. And it's best seen in parasternal long axis views. So we have also published on strain parameters, kind of quantifying and demonstrating this heterogeneous contraction seen in much of our prolapse related to this infralateral base having this curling motion. And basically this strain parameter is nothing else than the standard deviation of time to peak, so the time from the R onset to the max LV shortening by strain. So max shortening is negative, and each segment is shown here in a patient without arrhythmia. And notice the difference with patients with arrhythmia, where these peaks happen at different times. And this is because, again, you have these very abnormal mechanics related to the valve, which reflect on the myocardium. And so we have shown here that compared to patients without arrhythmia and prolapse, patients with prolapse and arrhythmia have a more abnormal, higher mechanical dispersion, particularly if they've had a more severe presentation with a defibrillator and cardiac arrest. So why do we care about all of these strain parameters and abnormal mechanics? Because they translate into traction on the papillary muscle and therefore fibrosis. So this is an example of a cardiac MRI with papillary muscle late gadolinium enhancement shown in this example. And this was initially observed by a group in Beth Israel in Boston a number of years ago. And then this other paper came out showing that gadolinium enhancement and replacement fibrosis can be found also in the infralateral base of the LV, which makes complete sense with the mechanics that I was describing earlier. We have also published on T1 mapping, which is a CMR modality able to show kind of more diffuse fibrosis rather than replacement fibrosis. We initially used kind of older T1 mapping techniques that are post-administration of gadolinium, and shown that MVPs with arrhythmia have more abnormal T1 mapping, so more diffuse fibrosis than patients without arrhythmia. And interestingly, only a small portion had LGE. So that's why, you may see a patient that comes in with a cardiac arrest and doesn't necessarily have LGE on cardiac MRI. This may be because, there's a different type of fibrosis that is abnormal in these patients. So now we use more kind of updated techniques with that T1 mapping methods and ECV, extracellular volume, that is calculated with the formula shown here. So I wanted to focus really on this parameter of risk. So I've talked to you about, the bileaflet phenotype, LGE, the mechanics as detected by strain echo, but really this is the parameter of risk that we should all be focusing on, in my opinion, and I'll tell you why. So this is the only paper that looked at this kind of longitudinally in a way. It's still a retrospective study, but there's a longitudinal assessment of mortality and kind of separation of three different categories of risk for ectopy. So there's like the mild ectopy, which is just PVCs that are greater than 5%, so a high burden. But the speed of the VT, that's an important parameter as well. If it's a slow VT, less than 180 beats per minute, prognostically that's more favorable. So that's the green. Still a slightly worse prognosis than the less than 5% PVCs, but the worst prognosis really is the fast VT. So not only many PVCs, but also a VT that's greater than 180 beats per minute. And of course, having had an ICD and nasty arrhythmias kind of predisposes you to more arrhythmias. So So what do we do about complex ventricular ectopy? So this is work by our own Paul Marano when he was at UCSF. There were a number of studies before we published this with him, showing that catheter ablation is actually effective. Usually the follow-up was about a year in prior studies, but Paul was able to kind of follow and look at these patients all over 9 years and showed that in the small group that underwent catheter ablation at UCSF, that about 5 out of 15, so 33%, eventually developed VT or VF and needed a defibrillator. So it may not be the solution to the problem, just doing an ablation. And multifocal ectopy and inducible sustained VT prior to the initial ablation were the best predictors of VT-VF long-term. And another interesting point that those that had a repeat ablation after having a defibrillator, so it had an EP study, had a completely new focus of arrhythmia, as if this complex ectopy were progressive and kind of worsening over the course of time. So what about genetics? There's really not much out there published. There are a few case reports, very small studies, but pointing out at the role of cardiomyopathy genes in those that have more significant arrhythmias. The idea of this particular group that published about filament C as being involved in risk of arrhythmia in mitral prolapse is that you have a genetic substrate with this weak myocyte coupling and the diffuse fibrosis, and then you have the trigger, which is the mechanics. There's this valve that's pulling on the papillary muscle and causing even more scar. So this is the so-called two-hit model that is hypothesized by these authors. Only 4 patients in this very small pedigree. So so the research that I shown is this enough to change or to determine our clinical management to have guidelines? And the answer is no, because all of these parameters are retrospective and based on single center studies. So the intervals of ambulatory EKG to pick up complex ectopy or even the imaging monitoring are completely unclear. Genetic studies are based on case reports or small pedigrees, so we really cannot use genetics to determine risk. So what do we need to do is really to develop these longitudinal multi-center cohorts, and this was highlighted during a recent initial BI workshop on the kind of the research needs for MVP. So just focusing on the right panel, really we need to kind of collect a number of unselected studies in these patients. So echoes, cardiac MRIs, PET to sort out inflammation in the myocardium, biomarkers and EKGs on all, and follow these patients prospectively. And only once we do this, we can really develop RCTs and develop clinically useful guidelines. So this was, kind of an introduction to really what my clinic is, which is aimed at really trying to get as much information that is prospective in these patients as possible. All patients in my clinic undergo a very detailed family history, because having a sudden cardiac death history in your family puts you at higher risk of having arrhythmic events. They all get a Holter. Holter is the only way we can determine PVC origin and then really attribute the PVCs to MVP. They're typically from the papillary muscles or the outflow tracts, as I mentioned. Event monitors, like Zio patches, are also fine if they've had a Holter, though, that is able to inform us about the PVC origin, whereas a event monitor at Zio patch is not able to really do that. We do strain echo on clinical echoes, so we add the strain analysis, and we actually do CMRs on everyone. So I'm lucky enough to have funds to cover research-based CMRs for those patients that don't have a strict clinical indication that will get reimbursed by insurance. But the nice thing is that the research-based studies are still reported in Apex. There's only one radiologist that reads with me, and it's always the same one. And so the cardiologist can actually act on cardiologists that, of patients that are not necessarily seen in my clinic, but are belonging to other cardiologists. They can act on the report of the cardiac MRI. And then I refer all my patients to the cardiovascular genetics clinic so they can get a clinical exome panel and sort out cardiomyopathy genes. And they also get a research sample for genomics discovery, let's say, for new variants that have not been published so far. So basically, this is my clinic. It's very niche and very focused, but there are no guidelines, as I mentioned, but there is this consensus statement, in case you're interested, that was published in Europe. And basically, they first of all consider the clinical presentation. So depending on, having just palpitations or syncope, things change quite a lot. So the testing is Holters, Holters for all, actually. And it really depends on whether the patient has VT or not. What we mean here is non-sustained VT. So if they don't have VT, then you go by the other phenotypic risk features that I mentioned earlier. And, if you have none, then you do episodic monitoring, a little bit more frequent. Again, it's completely unclear what this frequent and episodic means, really. We have no idea. And then if they've had a syncopal event, then that's when you should think about an implantable loop recorder, like a link device. So patients that do have sustained VT, it depends if it's high risk or not high risk. So if it's high risk, if it's fast, as the paper that I've shown you, then you should consider a loop recorder. If you have severe MR, of course, you have to consider surgery. If you don't have severe MR, then in high-risk VT, these authors suggest putting in a defibrillator, which would be a primary prevention defibrillator. If they've had an arrest, then of course you go with the secondary prevention ICD. This statement doesn't really take into consideration the cardiac MRI question. Who do we do cardiac MRIs on? Definitely, patients that have bileaflet prolapse and disjunction should get a cardiac MRI. And, if there's a complex ectopy on Holter or fibrosis, then you should be increasing the frequency of clinical follow-up in serial imaging. I do at least yearly. If there's no ectopy in normal CMR, then you can do standard follow-up. If you have syncope or depressed EF, or persistent palpitations despite nodal agents, then you should consider an EP referral. If you have monoleaflet MVP without severe MR, a Holter, a CMR, if you have complex ectopy, and if you have fibrosis on CMR, then again, increased frequency of a clinical follow-up. And then if they have, syncope or the other, presentations mentioned here, of course, an EP referral. So just a few words about how the clinic is set up. There's one clinic coordinator. There's a pool with nurses that cover inbox messages of patients, one research coordinator. There's a streamlined referral to EP. It's good to have one or two preferred EP providers where you refer all patients because they know the phenotype best. And of course, if severe MR is present, then they're automatically sent to the general valve clinic. I'm also part of that, but at least they can see a surgeon with expertise in minimally invasive repair and an interventionist with expertise in MitraClip if they're higher risk for surgery. And just a few, I think I have 1 minute left, just for a quick case. I actually had two, but I think I may just go with the second one. There we go. Okay, so this is a 36-year-old female with history of mitral valve prolapse who collapsed while at her child's preschool. And she received bystander CPR. She was found to be in VFib, had defibrillations, epi-amio with conscience that was acquired. And then she didn't have any past medical history. She had a family history of sudden cardiac death in her father, who also had MVP. She was on no medications at the time. Her exam was fairly unremarkable, except for a mid-systolic murmur and a click consistent with her MVP. And this is her echo that I showed you earlier. So this curling motion of the base, this rocking here, bileaflet phenotype, and adenal disjunction in only mild MR. Her EF was low normal after resuscitation. And to rule out Brugada, she had a procainamide study, but also a number of spontaneous PVCs that were all originating from the papillary muscles. There was no induced sustained arrhythmia. She had a CMR that showed LGE, and subcutaneous ICD was implanted. So she was started after her arrest and ICD placements. So she still had a very high burden of PVCs. She was started on metoprolol, which was not tolerated. This is seen a lot in these young female patients that are, blood pressure is borderline. So it's really hard to kind of put them on a good dose of beta blockers. But she couldn't tolerate metoprolol, couldn't tolerate nebivolol, eventually tolerated bisoprolol. So you have to kind of play around with the different beta blockers. Her PVC burden was reduced, her EF normalized. She had the clinical exome panel and no pathological variants were identified. So take-home messages: for severe primary MR, the importance of a valve center with expertise in mitral valve repair and MitraClip or TEER. And for arrhythmic MVP, there's really a lot more that is unknown or not completely well understood yet. The important thing is to remember that the risk is low but not trivial of death. And identifying the small number of MVP patients at highest risk is quite challenging. Most EKG and imaging studies are retrospective, so guidelines for primary prevention ICD are lacking. So while awaiting these prospective large-scale investigations and guidelines, we can follow consensus statements, and we can send patients to experienced referral centers. So sorry, I went a little bit over time, but that's it. And I welcome any questions. I'm going to stop sharing my screen.
Thank you. That was so fantastic, Dr. Delling. I have a few questions, but I first want to open up to the group. Does anyone have anything right off the bat that they'd like to ask? No. Okay. I like the shout out to Paul. That was nice. So I understand, obviously the population of these patients is quite low, so it's hard to come up with, big standardized guidelines. But in terms of just the natural history from what you've seen in your experience, is there a certain percentage I know you gave us very low percentages to begin with, but at what point in a patient's, disease course do you expect to see arrhythmias pop up if they're going to? And does repairing severe MR mitigate any of the arrhythmic risk?
Yeah, those are great questions. So in terms of the natural progression, I would say in my experience, I've seen mostly younger patients actually have the most severe arrhythmic complications, and I think that's because there's probably a genetic background. So they're kind of selected in a way compared to older patients that kind of live longer because they may have a less severe genetic background, in my opinion. So I do see, and also the Barlow's subtype of MVP typically affects younger patients, whereas the fibroelastic deficiency subtype with one scallop involved affects the older patients mostly. So Barlow's is, the arrhythmic complications are more prevalent in Barlow's, and Barlow's are more prevalent in younger patients. So definitely I would say younger patients. And also in postmortem studies that I've cited, 7% of sudden deaths. That's not trivial. And then the second question was the surgery. Yes, so there's really only one large study from Mayo from 1999, which I showed you from at the beginning, and they actually saw that surgery mitigates this risk. But these were patients with flail leaflet, so a specific subtype of severe MR. So we don't really know about these Barlows that have severe MR, where in theory, you should be correcting the mechanics with a repair, right? If you put in a ring, but you don't know necessarily if they have fibrosis that's pre-existing, just fixing the mechanics, will that help if they already have fibrosis? So we don't know. So we also follow these patients in these collaborations, let's say, in multi-center cohorts, surgical patients as well.
Awesome. One more question if you have time. So in terms of like long-term monitoring for these patients, is there certain, I guess, when you look at strain and CMR, are there any values like a linear fashion, like this value of strain will indicate my risk is higher, or is it something you will watch over time, or will you not repeat imaging after you've had initial imaging? And the same question for fibrosis. Is there a degree of fibrosis where you think this confers a higher risk, or is it more, or is there's no sort of threshold? And do you repeat any of the testing?
Yeah, that's another excellent question. You should have been at this workshop raising this point, which was raised, by the experts all over, all over the world. Exactly, this is what exactly we need. So we don't know. We don't know how fibrosis progresses. We don't know how often, we should be getting a cardiac MRI or even kind of strain assessment of these patients. So that's what we're planning to study, is really, with serial studies to see what the progression is, and how all of these risk factors kind of interact, because we don't really know, in a prediction tool, if one is more important than the other. We don't know. So that's all I can say. It's unclear.
Very exciting stuff. All right. Anyone else? Last questions for either of our speakers? Oh, you guys have left everyone speechless. Thank you so much, Dr. Perzo, Dr. Delling. Fantastic lectures about your niche clinics. We learned a lot, and the recordings will be placed on the California ACC Fit website for anyone that missed part of it. So thank you so much.
Thank you. Have a good night.
Yeah, thank you, everybody.
Bye.
Bye.